Thank you, Nitya, and thank you to the organisers for inviting me to speak here today. I am aware that I'm the second last speaker between you and a glass of wine, so I'll try and do my best to keep you actively engaged. So we move from bacteria to viruses now, and my task is to talk briefly about preventing and treating, actually, HPV-related diseases that lead to anal cancer. These are my disclosures. So I'm going to give a very quick overview of the epidemiology, just a couple of slides. I want to focus more on the natural history of anal high-risk HPV infection because I think an understanding of that natural history is absolutely critical to understanding how we might interrupt the progression of high-risk HPV infection to cancer. So very quickly, I think the next speaker will probably argue with me that HPV is perhaps the second most common STI, but very close. It's certainly right up there. The majority of sexually active people do become infected with this virus. Initially, upon infection, mostly no symptoms at all occur, but anogenital warts are a common consequence of low-risk HPV infection, and those low-risk types very, very rarely progress to cancer. It's, of course, what we're much more worried about is infection with high-risk HPV infections, which can cause anogenital and oropharyngeal cancers. However, having said that, mostly high-risk HPV infection clears on its own within 2 years, and then it progresses through squamous intraepithelial lesions and then may progress to cancer. In the cervix, there's good longitudinal data suggesting that progression rate is at the rate of about 1 in 80 per year, and it's the knowledge of that relatively high progression rate which is one of the driving forces behind the cervical cancer screening program. And I'll come back to anal data on that later in my talk. So a key feature of anal cancer, in contrast to cervical cancer, is that incidence is concentrated in a very few populations. So in the general population, the annual incidence is really rather rare, between 1 and 2 per 100,000. The risk factors for increasing are increased exposure to HPV, such as women who've had previous anogenital HPV disease, so after cervical disease, you're at much greater risk of anal disease. If you're an organ transplant recipient, so if you're immune deficient, you have an increased risk. If you're a HIV-negative gay man, you are at increased risk. And the most common rates, where rates reach 70 to even to 130 per 100,000 per year, is the population where increased exposure to HPV and immune dysfunction come together, HIV-positive gay and bisexual men. And so rates of 70 to 130 per 100,000 make it one of the most common of all cancers in that population. It's in the same league as colorectal or prostate cancer in that population, HIV-positive gay and bisexual men. I could show you incidence graphs from many countries, but I thought I'd show you some local data showing what has been found in many places, and that is that before antiretroviral therapy, anal cancer wasn't terribly common, but after people started surviving longer, the rates very much increased. So these are rates in HIV-positive MSM in the Netherlands, showing rates that peaked at over 150 per 100,000 and may have slightly declined. I think the general consensus around the world is that incidence rates in HIV-positive MSM have plateaued. Not consistent data yet of a decline, but certainly this is after an enormous increase in the early days of highly active antiretroviral therapy. The case I want to really spend a lot of time here is that knowing about the natural history is required for knowing where to intervene to prevent cancer. And so a quick cartoon here of how cancer develops, and this is very much based on the cervical cancer model. So people can become infected with anal high-risk HPV infection. That might clear spontaneously, and in a large proportion of people it does. If it doesn't clear, it then can progress to anal high-grade squamous intraepithelial lesions, or HATESL, I'll call that from now on, or it may regress. And then after a period of years, it may invade to become anal cancer. So I want to go through that natural history and just point out where we can intervene against this happening. So firstly, primary prevention is best if we can manage it, and we are fortunate to have an extremely effective vaccine for HPV, provided we vaccinate before the onset of sexual activity, because this is a prophylactic and not a therapeutic vaccine. So if we're using it in adults, it will only work against types that the person has not yet been infected by. And that's an important proviso in adults and means that it is less effective in general in adults. So the vaccine has been around now for over a decade. We now have licensed 2, 4 and 9-valent vaccines. They are close to 100% effective in preventing pre-invasive disease caused by the HPV type in the vaccine. So the studies have been done in the cervix. Outcomes have also been shown for vulva and anus, and some data emerging from those trials that based on prevention of chronic infection, that it does appear to be very effective against oropharyngeal infection, which is obviously very good news. As I said before, this is an entirely prophylactic vaccine. It is not a therapeutic vaccine, and that's why we aim it at ages before the onset of sexual activity. The good news for prevention of anal cancer is that it does appear to be effective. This was the pivotal randomised trial in young gay and bisexual men aged 18 to 26. They were required to be have relatively few sexual partners before the start of this study, because otherwise it was presumed infection would mean the vaccine wouldn't work. And the efficacy was shown to be about 75% against prevention of high-grade anal lesions. Presumably it would have been higher still had men all been uninfected at baseline. So good news for the future. What about our current generation of HIV-infected gay and bisexual men and others? Well, the good news is that it's certainly safe and it's certainly immunogenic. The studies are very clear on that. Unfortunately, only one randomised trial of efficacy has been done, which was of a majority gay men population, also included a small population of women. It was powered only to detect an efficacy in the order of 60% and was actually stopped early. But I think it was a bit of a shame it was stopped early, because in the intent to treat analysis, the efficacy was actually a non-significant 35%. As you can see by the confidence intervals there, there's every reason to believe that were it a larger study, it would have found that that was a significant reduction. This comes back to the fact that many of these people will have been infected, and the vaccine is not therapeutic, but it would protect against the vaccine types that the men had not, or the people had not yet been exposed to. This was a study of the quadrivalent vaccine, so this suggests that the nonavalent vaccine would have more potential to be effective against because of the inclusion of a greater number of vaccine types. So I think this is somewhat encouraging data, but certainly the vaccine is nowhere near as effective as it is in people before the onset of sexual activity. Many countries of the world have seen the rollout of HPV vaccine to girls only, to prevent cervical cancer, and Australia was like this until 2013. And these are data up until 2011 on reductions of genital warts in men before any male vaccination. So these reductions in genital warts presenting to sexual health clinics are not due to the vaccination of the males, they are due to herd protection. So you can see in the less than 21-year-old there was an 82% reduction due to herd protection, slightly lesser protections in the older age groups. These are heterosexual men. If we look in men who have sex with men, we see absolutely zero reduction. Not surprising. If you're looking at herd protection, you're talking about a different herd. These men are contracting their HPV from their male partners, and therefore are not going to be protected. So in order to provide future protection of the highest risk populations of gay and bisexual men, we do need to vaccinate boys before the onset of sexual activity. So moving to the next parts of the natural history, and that is infection with high-risk HPV and progression to high-grade disease, we're now talking about secondary prevention, and again, with using the cervical paradigm as a comparison, we would screen and treat high-grade lesions with ablative or destructive therapies, or potentially in the near future, more targeted therapies, which might be based on immune modulation, they might be based on antiviral drugs, or they might be based on therapeutic HPV vaccination. I should hasten to add there's no evidence available today that any of those work, but there is some promise for the future. So this is all based on the cervical cancer paradigm, and where population-based cancer screening programs are set up, you do see very nice reductions in cervical cancer incidence. These are all countries here in Europe, here in Asia, and here in a variety of other places which have population-based screening programs and have seen very marked reduction in cervical cancer in the years after introduction. So it's an interesting comparison and certainly attractive. So can we extend this to anal cancer prevention? So Joel Palevsky's group in San Francisco have been leading this advocacy for the last 15 years or more of screening with anal cytology and then with any abnormality, any cellular abnormality, referring them for high-resolution anoscopy, which is the anal equivalent of cervical colposcopy, and then if they get high-grade disease, treating with those ablative treatments, which could be electrocautery or a variety of other ablative therapies. I want to inject a note of caution in this analogy because there are some significant differences between the cervix and the anus. And firstly, I'll talk a little bit about differences in screening and diagnosis. So the screening threshold is different for these two tests. It's for any cytological abnormality, and whereas that does get you a similar sensitivity, it leads to a much lower specificity. So you get a lot more false positives when you're screening in the anus. There is no clear threshold for treatment in the cervix. All high-grade disease is treated, except in very young women. But it's thought we should probably treat the same, high-grade disease. In terms of HPV, many countries are now moving to primary HPV screening for its superior test accuracy in predicting disease. Could we do that for the anus in homosexual men? The main issue is that the level of high-risk HPV infection in the anus in this population is extremely high, in the order of 75%, with very high incidence per year. In some studies, including one we're doing in Sydney, it's as much as 15% per year incidence of new disease. So while this is recommended in women after the peak prevalence is passed, it's recommended to start at 30 roughly. After the peak of prevalence has passed, there's no age period in gay men where the prevalence declines. And the types you're interested in are broadly similar, although HPV-16 is particularly important for the protection of anal cancer. In terms of the epidemiology of the high-grade disease, the lesion that you're actually trying to treat, in the general population in women, you've got a prevalence of 1 or 2%, but in HIV-positive gay and bisexual men, if you have good high-quality, high-resolution anoscopy, then you're looking at a prevalence of between 30 or 50%, extremely high. We don't know about how often that regresses, but I'll show you some data on that in a moment. But in terms of progression to cancer, I mentioned to you we have prospective studies in the cervix which show it's about 1 in 80 per year. But if you compare the incidence of anal cancer, about 100 per 100,000 per year, to 30 to 50% prevalence, that suggests that the progression rate is substantially lower than in the cervix, based on a comparison of incidence and prevalence, not based on direct cohort data. So lastly, in terms of treatment, In the cervix, you remove the entire transformation zone and therefore reduce the possibility of any recurrence. Removing the transformation zone is, of course, impossible in the anus because the function of the anus would be removed. So the target has to be simply to ablate individual lesions. That means almost invariably multiple treatments are needed to get clearance with an extremely high failure rate. And if you keep that failure rate in your mind of about 30%, I think there's at least a concern that that might simply reflect the natural history of the disease. I just wanted to show you one slide of data on the natural history. There's very little data on this in the world because most people who are involved in this area are treating the lesions. In Sydney, we don't believe the data are in on effectiveness of treatment of high-grade disease, so we have a cohort study of about 600 gay men where we're describing this. I'm showing in this slide data on nearly 400 men with complete data at baseline 6 and 12-month visits. Of 160 men who had high-grade disease at baseline, that's about 40% of all men, you see that 34 or 21% had no high-grade disease at 12 months and at 6-month follow-up. So clearance of disease with no treatment. This is not a treated cohort. This is spontaneous clearance. And in terms of persistence, we saw that double positive persistence at 6 and 12 months was 56%. And these people may be getting multiple infections, may be early in clearance. We can't be certain. So we think we are seeing, just as we see in the cervix actually, a degree of clearance. The question of whether treating high-grade disease prevents anal cancer is currently under study in an extremely large randomised trial in the US, the ANCHOR study, which is looking at whether treating HL prevents cancer. So this is using the currently available ablative therapies, randomising to therapy versus watchful waiting. It's going to recruit more than 5,000 HIV-infected people and follow up for 5 years. So we will have an answer through this large, high-quality randomised trial, but not for a few years yet. So to finish off with tertiary prevention, of course, we can, even if we don't treat, even in the absence of an effective treatment for high-grade disease, we can try to diagnose cancer early. This is very important for anal cancer. It enables more targeted radiotherapy, high cure rates, less treatment-related morbidity. And the way to do that is through digital anorectal examination. I should say there's no randomised trial that this works, but it seems like a good idea and is recommended in the European AIDS guidelines, the USDHS guidelines, and also in our Australian guidelines. The goal being to advance the stage of diagnosis. It is pretty simple, but it does require a little bit of learning. It is not simply the same as a rectal examination, obviously. It's a detailed examination of the anus. So to summarise, what can we do now? Well, certainly we can vaccinate children, and that's absolutely the case. I think there is a lot of debate about whether we should be vaccinating adults, and in situations where drugs are publicly funded, the absence of randomised trial data is a real problem because until there is that randomised trial data, countries like mine won't fund these drugs. So if there's anybody from Merck in the audience, we really need that randomised trial. But there is some data that 9-valent HPV vaccine might offer some benefit, and I think that could be something you discuss with your patients. Regular annual digital anal rectal examinations are recommended in some guidelines. And in terms of screening and treatment for high-grade disease, my personal view is that this should be confined to places that are doing it in clinical trial settings to evaluate new and investigational treatments. I'd like to finish off by just saying if any of you want to know more about this, the International Papillomavirus Conference is in Sydney in October, so it'd be great to see you down there. Thank you.